All right, we're trying this for the second time. Dr. Benjamin Zaniello is joining the program. Dr. Ben, thanks for joining, all the way from Utah.
Howdy, howdy. Thanks for having me.
Oh, this is going to be great. I'm really excited to dig in. So you're the Chief Medical Officer at Collective Medical. And before we go down that route, I first want to know what you did prior, because my understanding is you started at a hospital and then switched to a technology company. Is that fair?
Yeah, I mean, it'd probably be even more fair to say that I've been all over the place. I actually did software before becoming a physician. I missed the technology, and I missed the economies of scale that go with working from a technology perspective. So while I was practicing medicine and actually doing population health-based research in Seattle, Washington, I continued to work with EMR manufacturers, all the big EMR rollouts that we've seen across the country for the last now kind of 10, 15 years. When I started working in the administrative perspective of medicine, I saw an opportunity to combine my technology background with my clinical background and became the CMIO of population health at Providence St. Health, the West Coast-based 56 hospital health system.
It's interesting that you say you have tech and physician background. Do you find that's becoming much more of a commonality? I mean, if you look all throughout history, I think a lot of the cool stuff that's happened has been cross-domain and cross-functional. I'm worried, especially for physicians, it seems like it's almost the norm that you have to know more than just the clinical practice, right?
Yeah, I mean, it's really interesting when you think of technology in healthcare versus technology in other practices. I mean, a great example is communication, right? We're using our computers to communicate. We are all in better touch with our far-flung friends because of Facebook or, Google or, our iPhones, et cetera. In fact, what's interesting is we all have adopted automatically, and our aged parents and young children have taken technology seamlessly into their lives, almost sometimes too seamlessly. They don't realize they're sharing every aspect of their life with everyone, including their neighbors. This has happened in healthcare in the perspective that technology is everywhere, but rather than being an amplifying or accelerating force, it is often viewed by most physicians as a disruptive and as a negative force. And going back to your kind of question of where I came from, I think like a lot of physicians that have an interest in technology, in my case, it's where I started. I was at Stanford during kind of the earliest days of the internet economy, and got into kind of technology as a means to a better end. Again, in healthcare, I think with kind of EMR Tech 1.0, we've probably seen the opposite of that we codified a lot of either bad practices or practices that made sense only because they were being done on paper into EMRs. So I am hoping that we are seeing the next wave with physicians and technologies and patients and all the care providers that use and interact with healthcare, where technology is going to stop being a negative disruptor and become, the true kind of Silicon Valley positive disruption, where it's actually making lives better. And you can't throw the baby out with the bathwater here. Technology has been absolutely wonderful for medicine when we think of all the radiological advantages and the new insights we're getting from data. But when you talk about the clinical practice of medicine, the day-to-day doctor-patient relationship that is still the bedrock of care across the world, unfortunately, for the most part, technology is a burden. It is something that has gotten between the patient and the physician instead of supporting that relationship.
Thinking a bit broader, would you say, and in a historical perspective, would you say that technology's unified the patient experience, or has it kind of created a further divide because it's further segmented the industry?
Sure. So I think it kind of probably depends on, which specific area. I think for the most part, it's actually created a division. And let me be more specific. So in the case that it is far easier today to get a CT scan, which is a fair amount of data on a disk instead of the olden days with an x-ray, which was literally being handed, the plastic that your x-ray was printed in. And so as a patient taking that from where you did your radiology to having your primary care doc take a look at it, a CD is necessary if you're talking about the advancement of CTs. But of course, the ability for a patient to actually get access to that data has been limited. So in the olden days, radiologists would actually hand you the x-ray. Now, if you want to get a CD of something, there is concerns of data privacy. There is concerns of access. There is HIPAA and paperwork to be filled out for your practitioner to get a hold of it for you. So in that case, technology has gotten in the way. There are some cases where, again, with the software in my company, where technology is supporting the sharing of data between hospitals. But take another use case when I think about being across the room from a patient that I'm caring for as a physician and realizing that for the encounter to be successful from a data collection standpoint, from both a clinical data collection, but also from a billing perspective, I have to make sure that all of it is input in the screen to my right. I am drawn to that screen in the less than 20 minutes I have with that patient to input that information. And that is, of course, pulling me away from that patient. I think most people are aware of the data that shows that providers across all care pursuits, no matter what type of practice they have, what type of role they have in medicine, they're spending more time looking at screens than they are with patients. And I think we all intrinsically understand that's got to be a bad thing.
Yeah, I definitely have realized that when I go to the doctor's office. It used to be where they're face to face looking at doctor patient. Now it's screen to doctor, and the patient's just kind of talking. Is that what you're communicating?
Yes,
Okay.
exactly. Exactly.
So when you think of, and this will probably transition into collective medical, what we talk about, the segregation or the how the technology's kind of made the experience a little bit more cumbersome. What's kind of the underlying root causes of that?
Yeah, there's a variety. Some are structural, some are more apocryphal than real. So simply structural, right? We have different technology vendors out there, different EMR vendors, Cerner, Epic, NextGen, Meditech, the 7 different vendors that McKesson or Allscripts own. And there is a technology limitation about kind of the standards for which they are supposed to share data. So that's a true kind of hard limitation that has to be overcome. But of course, it's been overcome in many different industries from a data perspective, and needn't be a block in healthcare. There are softer limitations. One of those is the privacy piece. I mean, the irony is, of course, if you ask most physicians and a lot of people working in healthcare what the P in HIPAA is, their automatic return will be privacy. And of course, ironically, it is not privacy. That P is for portability. And the original role of HIPAA was to facilitate the sharing of data, not be used to bludgeon anyone attempting to share data. So, an important piece of this is kind of the belief that due to privacy concerns, people have to be careful about who actually gets to see what data. So that's one piece of it. And even more kind of troublesome one is there is a lot of belief that data is power. And when you think about a value-based care world, or even a fee-for-service world in Medicare, where kind of the opportunity to charge a patient is the revenue source for many of our hospitals in many of our regions today, then they don't want to share data about the patient for concern that you may poach them. The reality is, we attribute these Machiavellian impulses to many kind of health systems across the country. There's very little of it that actually occurs, but it is a little bit of the overall gestalt behind this, that people are like, we can't share data because of HIPAA. We shouldn't share data because of either patient privacy or because concerns of poaching. And then finally, it's hard and expensive to do because of these technology limitations. In fact, all of those can be fairly readily overcome. They just have to be overcome via collaboration. And that's, again, what my company, Collective Medical, is very focused on, is this idea that through collaboration, through what's also known outside of healthcare as the network effect, that the more entities get on, the more collaboration is valuable to every node within that network, actually can overcome a lot of those, again, not very real, but always present limitations to sharing.
So let's get into it then. Can you overview, do you call it a solution then? Or is it a software package? How do you actually characterize collectively
Yeah.
what?
I mean, I think solution is a good word for it. I mean, certainly there is an underlying technology. There's software to what we do. We, we help create pipes into health systems. We create, data that is shared. We ultimately reveal kind of actionable information at the point of care. But if we've learned anything kind of behind our success over this last 10 years, is that the technology is really, again, just a means to an end. And what is the end that we are trying to achieve? In our case, it is that care collaboration, is that all these diverse entities, all the pieces of the care continuum, hospitals, ambulatory providers, post-acutes, all are collaborating around patient care. Technology is just our way of getting them there, and it is not the only piece of it. We have found it's very important in all the regions we work. We're now live in 26 states, that each region is different, that healthcare is very local, and the people that you need to bring to the table to collaborate is going to be slightly different based on a region's kind of makeup, their kind of health systems, their fee-for-service versus value care environment. And if anything, that's the most important part of what we do. Yes, we create we create with them a platform for them to collaborate using that platform, but at the end of the day, it's really the care providers around the table that are essentially making the difference. And I don't want that to sound too wishy-washy or modeling. Let me give you kind of a specific example. When we started working in New Mexico, and we had a wonderful opportunity in New Mexico where the College of Emergency Physicians, one of the largest bodies of ER physicians across the country, their local New Mexico chapter decided that they were kind of not managing the complex utilizers of the New Mexico effectively as an ED alone, and were aware of our software and its use in other states. So they were interested in us. Meanwhile, health plans that had used us in other states were aware of our support of managing those complex patients as well, and the fact that we could support them in decreasing ED utilization and what are often called avoidable ED visits, kind of right sizing, right placing care. These two groups partnered up with the Hospital Association in New Mexico and collectively invited us to roll our software across New Mexico. Where I'm going with this story is we deployed across New Mexico. We brought all these groups of people together. Again, we're creating a platform. What is critical about what we do is how it is used. And these three groups sat around a table and created a regular cadence of meetings to discuss essentially patient care and how they could best care collaborate on the opioid epidemic in New Mexico, on complex patients within New Mexico, behavioral health, et cetera. What they were so struck by and kept repeating to us was that this was the first time that the health systems in the hospital association, that the ED docs as the frontline providers, and the hospital, the health plan representatives had all sat down at a table to discuss something other than contracts. That this was a great opportunity for them to finally collaborate on patients, of which there was tremendous latent demand. So again, going back to your original question, which I probably lost the tail of days ago, the, the that technology is a very critical piece of it. And we talk about, we have a best in class patient matching, because of course a big part of what we do is understanding that the patient in front of you right now at that post acute or that emergency department is the same patient that we have a tremendous amount of important information on. We, from a security perspective, we have high trust certification to show that we essentially are good stewards of everyone's data, blah, blah, blah. Technology is a very critical piece here, but in the end case, it is the use of the software and how we facilitate that use to create these care collaboration networks.
A lot to unpack there. When you talk about the different nodes and the partnerships, can you speak to, I have to imagine it's incredibly difficult to start these type of initiatives because the underlying value proposition is in the connections and the aggregate data that you're able to bring together. So can you walk us back to when Collective Medical was just starting, and how was it trying to get the buy-in, like you mentioned, with New Mexico partners, and do that across the board so people can realize this potential power of being able to see across different systems?
Yeah, I think you're highlighting, the critical issue within the network effect, that there essentially has to be a network for there to be an effect. Um, I love to use the analogy of the middle school pool party, which is, group of gawky adolescents, standing around a pool and desperately wanting to jump in and have fun, but somebody needs to jump in first, right? Um, and that is, a problem we encounter across our markets, even when we kind of first went live in Washington State now, almost exactly 10 years ago, is that somebody needed to go first. So it takes vision, essentially. It takes some amount of kind of innovative impulse, usually among either the first health system or the first health plan or group of behavioral health clinics in the case of New Hampshire, where they say, this problem, this management of complex patients, this whether it's the opioid epidemic or workplace safety, again, just use cases that have been used across our platform. This problem is big enough that we are going to stick our neck out and be the first. Now that's obviously easier when you are Dartmouth in New Hampshire and you're the largest health system in the state, and by saying we're going to move forward, this means the likelihood that other entities will probably follow. And that's part of what we do, is kind of identify who are kind of the most innovative players in each market and talk to them first, knowing that if they go, others will likely go. But it's not always the academic institution. Again, often it is the community hospital that is very much aware of the problems in their community and looking for kind of the best way to manage it. And sometimes it's desperation for how this could work. I comes to mind is Community Hospital of Monterey Peninsula, also known with the adorable name of CHOMP. A set of wonderful, innovative, visionary ED docs. I could not attach enough superlatives to their names. They essentially said, we are not doing right by the sickest and most needy patients in our emergency department. We are treating them transactionally each time they come in, and we need to start acting more like primary care, because they are using, and so much of our population is using, the emergency department as primary care. So we need to start thinking longitudinally. rather than fix the problem that they're here for. We need to listen and fix their underlying issues that are creating that problem. The patient is complaining to me of their cough, but the real issue is the food and shelter insecurity that is driving them to go to the emergency department for, what we call an avoidable ED visit reason. And that's what they did at Chomp, but and really helped trigger our network across California. But this has been true state after state. Interestingly, that story at Community Hospital Monterey sounds a lot like the origin story of our company, which was a Boise, Idaho social worker in one of the busy EDs in Boise that was concerned that she was not taking great care of her patients and being acutely aware of that even if they did their best, that this same patient was utilizing other health systems and getting the same transactional fragmented care. So she became a living healthcare information exchange where she essentially kept track via pen and paper of these patients. Other hospitals would call in and she would say, well, I haven't seen that patient, but I know that this hospital has, and this is their recommendation on how to manage them. That, of course, did not scale, as you can imagine. And this is where technology does become helpful. She had heard of this internet thing, but even better, she had a college-age son, a sophomore in college, and she dragooned him and his roommate into writing the first version of our software. Then, fortunately, a group of ED physicians in Spokane, Washington, working for Providence, the health system that I came out of, were also looking for a way to share information among the health systems in the eastern part of Washington. So they actually started working with the kind of earliest version of collective medical, and 10 years later, we're now in 26 states with over 700 hospitals actively using our software.
Those are great stories that I think get right to the heart of the difficulties in healthcare right now. It really does take a few individuals that have the patient in mind completely to be able to take these leaps of faith. Because I wouldn't say the system's not really built for this type of change, right? Because we spent historically everything worked in a silo in small towns, small hospitals, and it's only over the past 10 years or so where everything's kind of come to a head, and these type of solutions are much needed, right? Because we have to adapt, or there's gonna be some sort of breaking point. Would you agree with that?
Absolutely. I mean, when I think of how medicine used to be practiced, and I'm a born and raised Kentuckian and went back there for medical school, and still in some small towns in the United States, you have the general practitioner that also sees patients in the hospital, and there is a siloed healthcare system, but essentially everyone's in it. That is no longer true. All those hospitals are now part of much larger for-profit health systems, and generally speaking, those health systems are making decisions at a corporate and not at a local decision level. Not to mention that there's been fragmentation in specialties, and there are very few doctors that practice in and out of a hospital today as we become increasingly specialized. And for the most part, this is good because we are doing so much more in healthcare, and in some cases reducing costs of some of the kind of critical life-saving treatments that have debuted over the last 10 years. But you're absolutely right. The cost is more information. I like to use the little bit the rhyme of the ancient mariner here, that it does feel often like water everywhere, not a drop to drink. That there is more and more information out there, but actually, is it information? It's more data, and whether or not it can actually inform your care is highly variable.
How would you characterize the benefits that you get from collective medical? You hit a couple of them, but I'm guessing they're numerous, right?
Yeah, well, I mean,
You think
let's.
so? You're
Yes,
biased, but I think
everybody take it with a grain of salt. But as I always point out, I put my money where my mouth is, which leaving my kind of health system executive role to take a role at that time was a very small company, though we've certainly grown as our customers have grown as well. There are a couple of things I always like to enumerate here. I mean, we just to kind of continue the previous thread, that kind of data versus information. I always like to kind of point out that as we talk about interoperability, and interoperability, the word feels like another technology trap when we talk about the goal is interoperability. And my perspective is interoperability is just means to an end. The end is the collaboration piece where people are collaborating because they are now sharing data via interoperability. Because essentially what can happen with interoperability, and if you even look at, let's take, the largest EMR provider today, Epic, for most physicians, there's already too much data in their EMR on a single patient to effectively manage them. It's part of the reason you're always staring at a screen, is because you're always looking stuff up or having to input new data in certain forms so that it is captured in these massive relational databases that are EMRs. Epic then added on Epic Care Everywhere, which on the face of it is pretty awesome. It essentially says every Epic system has visibility into the patient data across every Epic system. So if I'm seeing you, I can go to Epic Care, the Epic Care Everywhere tab, and see your last visits in a different health system, maybe across the country. So from an interoperability perspective, other than the fact that it's only Epic systems, it doesn't include Cerner, it doesn't include other EMRs, it's still actually really, really helpful. But again, up to a point, I've just said there's already too much data in EMRs that I, as a physician, can effectively process, prioritize, and use in your care. I've just added every other EMR every other Epic installation across the country to that. And then you throw in these healthcare information exchanges, which are kind of freestanding portals, which maybe in each state attach all the health systems. So now I have access to Cerner and all these other things. But again, I'm just accumulating more and more data. And particularly in a 20-minute primary care encounter or an even faster paced ED encounter, my ability to access, process, and make actionable that data is next to impossible. So our role and how we use our technology to support that clinical decision making moment when you interact with a patient is we aggregate all that data through partnerships with HIEs, through our own hospital connectivity, through connecting to advanced directive registries or drug monitoring databases, anything that could potentially have actionable information in their vast data stores. We connect all of those. We bring it to the point of care. We risk stratify it so that, for example, if I'm sitting in the ED and you walk in and you broke your leg last year and that's your one hospital encounter, I shouldn't be alerted about it because that will just contribute to the alert fatigue as EMRs desperately try to manage all of their data. Instead, if you've had multiple encounters in the last 6 months, let's say you're bringing your child in and this is a repeat visit for a chronic cough, right? I should know that as an ED practitioner or in my primary care office or in the hospital because those number of encounters spread across otherwise fragmented health systems for upper respiratory complaints could indicate pediatric asthma at that point undiagnosed. And is a great opportunity as an ED practitioner to, again, right place your care so that you actually start getting managed as someone with pediatric asthma, not someone that is a high ED utilizer, which no one actually wants to be. Or as a primary care physician, I know looking at those encounters that I need to find what is the root cause of this cough and focus on that piece. So if I kind of define those as different value propositions, one piece is that aggregation of data, the normalization of it, so boring but important. And then the risk stratification of it to determine what part of that data is actually information and actionable. And then there is also a workflow component, and that harkens back to how we started this call about the doctor-patient relationship and staring at a screen. Part of the reason that they're staring at a screen is to better access that information. And if I want to go to my HIE, if I want to look up your drug history, I may have having to go to another screen. What's critical for us is that we try to be as agnostic as possible, and we try to shove that actionable information in front of you in the most workflow centric manner. So for an ED doc, it's in their track board, which is that big screen with a list of patients and what room they're in and what nurse is managing them and what care provider is seeing them. We actually will put that a link to that information there so that you can easily access it. Sometimes in a critical access hospital with 20 beds but a very busy ED that's still primarily paper-based, we'll put it in a fax. The important thing is that you have easy access to it right before you see a patient so that it can support your care.
Is surfacing the data the trick, and formatting it in a way that's actionable on first glance without having to sift through it? Is that the trickiest problem you have to solve? Because it's easy to, when you talk theoretically, it sounds really great, but then every patient has to have completely different data. So how do you surface that in a way that's uniform but also individual to the patient?
Well, it's an interesting question. I mean, I think if I take surfacing as risk stratification, understanding kind of on what patient, which information, it is kind of a thorny technological problem. What's interesting about it is that understanding of what data do I want to understand about a particular patient, physicians for the most part have figured out, and we're just making it easier for them to access it. So in other words, if I walk into an ED, the ED provider will tell you they want to know anyone that's had multiple visits to any health system over a period of time, and that's that classic high utilizer. They want to know anybody that's had a recent inpatient visit, because anybody that's been admitted to a hospital or to a post-acute facility is generally a more complex, sicker patient. Oh, and there's those readmission penalties for hospitals if somebody's going to be readmitted. So there is a cost part of that as well. I want to know anybody that's a traveling patient. So that's someone that's visited multiple health systems in a short period of time, because again, clearly there's fragmentation there in their healthcare and they're at risk. Nobody is clearly owning them, whether it's a primary care doc or a physician. Speaking of ownership, I want to know who's on someone's care team so that if I discharge them from my hospital, if I have only 20 minutes in the clinic and I'm focused on a particular issue, I know that other people are caring for other aspects of that person's care. And then it gets very specific to the environment. An ED wants to know if you've had any history of violence. And I know that sounds really depressing, but the statistics are really depressing. If you look at any survey, particularly of nursing staff, but all care providers in the ED, the number of assaults in an ED is mind blowing. The last one I just looked at that was recently showed to me said that 1 in 7 nurses were being assaulted every month. So not over a year, not in their careers, but every month, 1 in 7. So this is a big issue: workplace violence and workplace safety. So in an ED, they will ask us to surface any history of an assault or violent act in a hospital. And it's important to point out here that this is not workplace safety is not people coming into hospitals and wanting to do harm to providers. The actual percentage of that is quite low. It has to do with being in a scary place, the ED, in a scary situation. You're sick, you're dying, you have a behavioral health issue, you have a psychiatric illness, you don't have your medication, and you are not in control of your faculties. That is the most common reason why nurses and care staff are assaulted. So again, if you have a history of that, that is one of the information that we surface to care providers, not so that they can arrest you in the emergency department. In fact, so they can proactively manage that risk. And a small hospital in Kentucky, for example, that involves asking the security guard who could be on the second floor of the hospital doing rounds to actually just be present in the emergency department when that person is brought back. So again, that's just one of these use cases, but essentially physicians, care providers in most care settings have an idea of what type of information they want to see. It's just that we need to aggregate it for them. And then we need to make it easy for them to manage that risk, to essentially titrate and say, I want to see people with this certain number of encounters, with this background, et cetera. And we allow them to do that all individually, because the type of risk that a Kentucky or West Virginia community hospital is seeing is very different from what San Francisco General is seeing. Yes, they both have incredibly high volume emergency departments, but they're seeing different types of patients, and they actually want to see kind of a different type of information on those patients.
That insight is so fantastic. I never would have. Nurses are amazing, aren't they? I never would have thought. I know all the stuff they go through just from a healthcare standpoint. I didn't even realize about the assault. That's interesting that you share.
Yeah, I think it bears repeating over and over again, and I will be the first to say this as a physician, that nurses are the backbone of medicine. And it is their practice and their mission that that has kept and will continue to keep our healthcare system afloat. And it's why when I think of best practices, it often involves give more to the nurses, obviously within their scope of practice and their ability and salary and all of that to do it. But the more that they do, the better we do.
Yeah.
As a general rule.
Plus one. I completely agree with that. Equally appalling statistics are the opioid crisis. I recently got done reading Dope Sick, which I'd encourage anyone that's in the healthcare industry to check out. Before going into how the solution you guys provide help counteract the opioid crisis, I'm just kind of blown away that the opioid crisis exists and happened. It happened within the terms of engagement within the healthcare industry. They didn't, maybe their intentions were off base and not aligned with a lot of other healthcare practitioners, but they did play by the rules, which is kind of scary.
Yeah, I mean it's a fascinating tale, and it will be continued to be retold with new kind of insights every day. I mean, Dope Sick's wonderful, Dreamland by Sam Quinones, all of these kind of are great approaches to telling this story. I do always like to emphasize, and I'm not going to defend pharma here, but there's no real villain here. There are definitely some bad actors. I mean, the pharma industry definitely shifted from trying to give men erections with Viagra to trying to kind of push opioids when they don't necessarily need it to be. That said, I came of age in my medical training when good academic medical centers were training all young doctors that pain was the fifth vital sign, and that we were under managing chronic pain. And yes, some of that could have been through an insidious pharma marketing, but a lot of that felt and rang true. And of course, opioids felt at the time to be a better way to manage that pain. I don't look at my medical school preceptors and think that they were bad actors with the pain as the fifth vital sign, because we often undermanage pain. So I think there's a variety of pieces here. I mean, I always talk about the opioid epidemic as being more stemmed by economics, and again, not pharma greediness, but Rust Belt, the closing of factories, right? There's also cultural reasons. We are culturally more oriented to solving things with a pill than through physical therapy and kind of more conservative measures. We focus on kind of opioids for the management of pain. But when you think of the number of heartburn medication that is prescribed across this country for something that could be easily solved with dietary changes, I just cascade myself for using the word easily, because if they were easily solved, people would do them. But a reduction in alcohol, coffee, chocolate, late night chicken wings would mean that you'd have to take less heartburn medication. So again, I just want to say cultural, finance, some bad actors, there's a lot of things that are going to play here. But we're in this situation today. What can we do about it? Well, again, first of all, I always say let's not play the blame game. I mean, even in the medical community, there is a tendency to say, well, ED doctors are giving out opioids like candy because they're in such a rush to get those patients out of the ED. They'll do anything. And if it's an opioid a patient wants, they'll give them. Or people point to dentists and say, I got my tooth removed and they gave me 40 Vicodin and I only needed once. So I think we need to move a little bit beyond the blame game and kind of focus on what are kind of the best possible solutions. I mean, we have a little bit of a tagline around opioids that kind of the most radical approach to this is care collaboration. So is to stop pointing fingers at other medical practices, at each other, at the patient themselves. That, I guess, if I emphasize one thing, that to blame the patient for this is kind of the biggest mistake. This goes together with the stigma about addiction and mental health in this country in general. This idea that addiction is something that somebody can will themselves in and out of is like saying that you can cure diabetes with your mind alone. We're comfortable with diabetes and that not being true. We need to also be comfortable that people with substance use disorder need real medical help for the real medical illness that they have. And I think there's a variety of ways to overcome that, but collaboration is a big piece. It's understanding when someone walks into your emergency department, into your primary care office, and first identifying them at risk. And so often, even that first step is not being done. Either there's two pathways, which is one, not acknowledging that they're at risk because they don't fit some sort of pre-existing but proved wrong now by data stereotype about an opioid user. This is your New England, mother with a migraine that comes into your ED that you can't imagine has substance use disorder, but every depressing YouTube video out of New England shows that can certainly be true. So that identification is really kind of the first piece. Is this person at risk? And again, not viewing it as they're here to trick me into giving them medications, that this is all about drug diversion, which absolutely exists, but the vast majority of patients going to a health provider with pain do have real pain. And opioids can be a short-term fix to that. It's working with them to understand what the kind of long-term game, but first and foremost, you have to identify them.
Yeah, and I definitely didn't mean to infer about pointing fingers at anyone. I'm more just kind of blown away that the system is built to have so many checks and balances to prevent this, and it still kind of slipped through the cracks across the board. Really, I think so many different parties had a piece to play, and I completely agree with your message. It's all about let's fix it, right? It happened.
Yeah.
We can't reverse the past, but let's figure out how to fix it in the future. So maybe you could talk through how collective medical's helping kind of counteract the toxic situation we're in.
Yeah, great. So, I mean, first and foremost, there is that identification piece. So, when I talk about kind of managing risk in a ambulatory or hospital setting, identifying the patients at risk is really, really important. And some of that can be very basic. It's a person. I remember one of the first people that I kind of managed using collective software was someone coming down the Northwest Corridor on I-5 with 7 emergency department visits for stomach pain that had clearly been identified as a drug seeker because these kind of recurrent over a weekend, stomach pain without a lot of kind of active manifestations of other disease. Well, of course, from a collaboration standpoint, because using collective software, I could see her longer clinical voyage. I could see her kind of immediate need. I could see standing back that she was a type 1 diabetic with gastroparesis, very common manifestation of diabetes that manifests as stomach pain, that due to her not having the right site of care was being treated as a drug seeking individual, and she just needed better kind of pain management, which in her case would have been management of her diabetes and not in fact a narcotic. So kind of step one is that identification piece, because so much of this is not about the pejorative. It's not about, quote, the drug seeking individual that's trying to drug divert, or because they're an addict, they just want drugs. They actually have pain management needs. They're in real pain. So how do we most appropriately treat them? And it's often not in the emergency department. So it's getting them to a better site of care. Then step two is, great, we've identified this person at risk. How can we help them? So I've mentioned kind of the other site of care. For a diabetic, it could be their primary care doc or an endocrinologist. For somebody with behavioral health problems or substance use disorder, it may in fact be rehabilitation at what's called a medication assisted therapy clinic. So it's essentially easing their passage from their kind of site of care and what they are viewing as their need, which can sometimes be a opioid, and actually getting them to the right place that can manage them more appropriately. And you know, to use the cliche, it takes a village here, in the sense that it is involving, from a collaboration standpoint, multiple diverse entities being online and creating essentially the opportunity and the actual information for an individual patient, because everybody's needs are going to be different. Their actual underlying cause of their pain could be different. Their region that they come from could be different. You know, there are kind of a million different examples of this, but I think one of the most visceral for me, for example, is with neonatal abstinence syndrome. So neonatal abstinence syndrome, often called NAS, is one of the most tragic after effects of the opioid epidemic. It's essentially children that are born in withdrawal because their mom was an active user during pregnancy. And again, this is happening in the thousands in Appalachia, but also outside of Appalachia each year. And what's particularly depressing about these children is not actually their short-term treatment. Hospitals in Appalachia, academic medical centers, West Virginia, University of Kentucky, Louisville, are actually very good at identifying these children, again, because they're treating generally their mother as a high-risk pregnancy, and actively and appropriately managing the withdrawal for these babies after they're born. The problem, of course, is they are then discharged from the hospital in good shape and go back to their communities, which often are far from the academic medical center where they had their high-risk care, across state lines, in a community, in a holler. And there, that kind of fragmentation and that lack of sharing between hospitals can be a problem, such that when that child appears in another emergency department, away from where they had initially gotten their care, and frankly, if you've seen kind of a fussy newborn, they are not explicit about what is driving their fussiness. They would have a fever, they're red. This could be a respiratory issue, a digestive problem. Generally, to an ED physician, it's very hard to guess that the reason for all this constellation of symptoms is actually opioid withdrawal. It's usually the last thing you would think of. And certainly from a proactive care perspective, the last thing you would give a fussy newborn in emergency department is proper opioid withdrawal management. But in fact, that is what these newborns with NAS do need. So how we facilitate that, back to that collaboration orientation, is that when these children are born, in essentially their patient record, a care plan is designed by the neonatologist that has cared for them at birth about their opioid withdrawal plan. And they are flagged as a child at risk of neonatal abstinence syndrome. So whenever they go to a new hospital that's on our network, as they're coming into the ED, that ED care providers that knows that there is a chance that this child is suffering from withdrawal. Now, they could just as easily have an active infection, have a GI problem, et cetera, et cetera. But the important thing is that provider now has added to their differential the possibility that this 2-week old, 4-week old is in active withdrawal. And again, just a fabulous opportunity. By sharing data, by pushing into their workflow, they can actually take better care of that newborn.
Well, I appreciate you being, even though it's not great to talk about. I appreciate you not sugarcoating some of these situations, because I think that's the most important thing, is communicating what the reality is and finding ways to counterbalance that or counteract that. It's hard for, me. I work in pharma. I don't get to hear these stories or experiencing these stories, but they're so important to share, because that's what we're trying to do in healthcare, is to make patients' lives better. And if we know some of these things are going on, it's important that we all take action and think critically about them to try to solve them. And I'm wondering, pivoting a little bit then, um, what does the long term look like for collective medical? I guess what's kind of the end goal, or do you have you thought in terms of that?
Yeah, I mean, frankly, there's just a lot of work to be done. I mean, I think I mentioned earlier that we're at 26 states. I mean, I think the end goal is a national network whereby there's kind of facilitated exchange of data and care collaboration on patients. I mean, we have wonderful, depressing data about essentially kind of patient travel. When we first turned on the great state of Alaska and the hospitals in Alaska, we were surprised. I want to point out, nobody in Alaska was, but we were surprised, as was all the physicians in, quote, the lower 48, that so many patients are actually getting healthcare in Alaska. And again, I can't articulate to you, it's because they're on cruises or fishing trips or they're oil workers, but thousands and thousands of patients are being seen in a Seattle hospital or a Massachusetts hospital, and then in a short period of time having care done in an Alaska hospital. So I think first and foremost, the onus is on us is to connect as many of these nodes as possible. And then also a variety of nodes. I talked about kind of, we learned to better support in our evolution as a company to provide better care in the emergency department. We needed to bring in the other aspects of the care continuum, particularly behavioral health, but also post-acute, ambulatory specialists, et cetera. I think we will see more and more varieties of nodes join our network as care continues to become kind of more fragmented and complex in that regard. So I think that one piece of it is just the amount of kind of players on your network. The second aspect is essentially kind of what the platform is used for. I mentioned the opioid epidemic. We talked about workplace safety. Value-based care is another piece of this. We're actively used by some of the most sophisticated health systems like Kaiser to work as a pseudo-integrated health system, even when patients are moving outside of network. I think as healthcare continues to grow, that approach, which is, you are technically a hospital in competition with me, but we are sharing the same patients and we are actively managing the care, and we'll do a better job if we collaborate. There are more and more use cases like that every day.
Do you foresee a future where collective medical augments or assists in actually determining what the doctor should do for the patient?
Yeah, I mean, we go at kind of great pains that to say that we are kind of supporting clinical decision making, but we are not kind of making the decisions. And I think that is a really important aspect of medical care in general. And certainly, I came out of a population health background where I looked across kind of the ACO, the accountable care members that my health system was at risk for, and said, I really wish the physicians would order fewer MRIs for headaches and instead started with CTs. And I had a point about, reducing cost in healthcare and also sometimes quality. But at the end of the day, I had to facilitate their clinical decision making so that they could make the right decision for themselves and for the patient. But what I couldn't do is make that decision for them or attempt to, because at the end of the day, the critical and best part of medicine is that physician, that care provider, that nurse relationship with the patient, and the practice of that transactional care, and not wanting to be another thing getting in the way of that, to make that transaction better versus trying to push it in another direction. And that's what I think is a really important part of what we do, which is we want to make your interaction with the patient, you as a care provider, your interaction with the patient better, because we are giving you information about the patient that will inform your care and make it, ultimately a better experience for you both. A big part of provider burnout, for example, is just feelings of inadequacy, and the opioid epidemic has really fed that, because I may identify you as someone at risk for substance use disorder in the emergency department, but that doesn't help you, right? And I became a doc to help people. That's what care providers want to do. So, if you talk about kind of where we're going, and I'll give just one specific example as we get to the top of the hour, which is in the opioid epidemic, we identified these people at risk in the emergency department. But then the problem is, where do they go? How do you support them? Well, ED docs came upon the very good idea of actually starting rehab in the ED. And it's generally called ED as bridge, and essentially involves giving them methadone or buprenorphine, the other kind of treatment we use in substance use disorder, in the emergency department, so that it bridges them till they can get to a medication-assisted therapy clinic that can finish their rehabilitation. And I think that is a great opportunity to, again, support patients better, because they're actually, these people with substance use disorder are actually appearing in the emergency department. So it's a great place to identify them, but then it's a great place to actually start them on the pathway to getting better. And that, of course, is support for providers, because there's nothing more frustrating than interacting with a patient that you don't feel that you can help.
Right. One final theme I wanted to get your thoughts on. There's this notion of patients owning their data that's starting to surface, and some companies are starting to try to figure out a way to make that a reality. Is that something you guys think about at Collective?
Oh, absolutely. I mean, I think the end goal is that all, we are kind of extremely vocal about, we don't own this data, that health systems don't own this data, HIEs don't own this data, Epic doesn't own this data, that the patients own this data. This is their data. Um, and any kind of facilitation to their kind of access to it, we kind of robustly support. I can't kind of underline that more. We heretofore do no patient engagement. Our patient engagement is always through the hands of the care providers and kind of supporting their care of a patient. But, our standpoint is, the faster we can get to the point where we can facilitate the share of that data, so that patients can, quote, bring it with them, et cetera. Um, we're robustly for. I mean, we feel, frankly, that we do that today, in the sense that we're often asked by, people interested and concerned about privacy. We had early talked about what's kind of blocking the sharing of data that we have to manage. We're often asked, how do patients feel that as they walk into an emergency department or admitted to a hospital, that you're automatically sharing data about them from other health systems? And my response is, if you talk to a layman that's not deep in healthcare data or interoperability, that doesn't work at a hospital, about this, their response is almost always, that's how healthcare should work. That when I'm when I'm talking to my doc, I want them to know everything about me, because I recognize that actually means better care for me. So I guess that was a long answer to your question, but I guess we are enthusiastic about it, and we'll kind of facilitate it in whatever way we can, with the same kind of asterisks about, that data breaches are a real concern. I personally, as a physician formerly employed by the Veterans Administration have seen my data float across the internet in amusing and sometimes depressing ways.
Well, I think that's a great note to end on. Is there any closing thoughts you'd want to share with the listeners?
Yes, first and foremost, I love the VA, and that was not meant to be a knock on them. No, I do think this is an exciting time in healthcare. I like any doc and somebody working in healthcare tech, probably spend too much time complaining about the EMRs when in fact we're just at step one here, and we're entering kind of the next phase of healthcare technology, and it is addressing effectively a lot of the problems that we've talked about, the opioid epidemic, provider burnout, patient engagement. More and more solutions are coming. I definitely think collective medical is at the forefront of that, and it's an exciting time.
That's great. Well, I can't thank you enough for coming on. You triggered some thoughts that I had no idea we'd get to, and I'm definitely going to have a few more things to research now. Um, Thanks for sharing your perspective. This has been great, and I wish you all the best of luck with collective medical, getting the interoperability and all the partnerships up and running, so we can have this fully immersed national system. That sounds like a great future that we could strive for.
Awesome. Well, again, thanks for having me. I love talking about this. I'm passionate about it. And again, I think we're moving in the right direction.
All right. As always, best thing you can do is share an episode with a friend, help spread the word. We've had a great success and got a lot of good feedback from the podcast recently. So I can't thank everyone enough for listening. And we'll come back with another great guest next time. Thank you.